So I'm going to say good morning to you and welcome to our 13th annual Morning Matters event. And I'm going to toast you all and say good morning, and I hope you've all had a cup of joe to get your day started. Have the pleasure of serving as the president and CEO of Amoskeag Health, and I've been with the organization now for probably 25 years, and that means I'm all of 42, which is just amazing. I don't know why they would hire me that young. But here at Amoskeag Health, we have an integrated care model, and really our focus is on trying to provide access to everybody who needs it, culturally sensitive, non-judgmental, and compassionate care. We're here to meet our patients wherever they're at. And in this particular pandemic situation, that has been a fun and interesting challenge. So they're getting care much like you're getting this conference via virtual means whenever possible. And certainly we're here to try and meet the needs of individuals who are having those barriers because of their socioeconomic status, language barriers, and other obvious concerns that our communities all face. For 13 years, the Dr. Selma Deitch Center was known as Child Health Services, and they started this breakfast in a hope of spotlighting the needs of the children in our community and their families. And so we're really excited about the opportunity to have this focus day on perinatal substance use disorder, or prenatal substance use disorder, because we know what an important topic it is, and we have some wonderful speakers for you. This virtual breakfast this morning is possible because of the generous support of our underwriting sponsors, Dartmouth-Hitchcock Medical Center, People's United Bank, who's sponsoring our keynote speaker, and our program sponsors, AmeriHealth Caritas, CGI Business Solutions, Harbor Group, and New Hampshire Healthy Families. So we really want to say thank you to all of them. As you can imagine, these kind of events aren't possible without their support and the support of many others. This morning, you're going to hear from medical professionals, elected officials, valued volunteers on how we here at Amoskeag Health, in partnership with our partners in this community and statewide, are trying to provide resources to help support women who and their families who may be experiencing substance use disorder. There is no better advocate for New Hampshire's substance use addiction epidemic than our governor, Chris Sununu, and we're very pleased to have him here with us this morning and to have him share some information about the state and where we're going and how he is working to address this issue. So I thank you so much, Governor, and I'm going to give you the stage.
Great. Well, thank you very much. Great to see everyone. Good morning. Good morning. I do have my coffee. I dug in early. Lately, I've been drinking, it's like coffee and chocolate is basically what I'm living off of right now. I think a lot of us are, and it's funny times, to be sure, challenging times. So I think first off, thank you guys for hosting this. Chris, you obviously and your team continue to do an incredible job down there. You guys are on the front lines of a lot of different issues, but this is a big one. When we talk about SUD, when we talk about what's happening with families, with what's happening with moms, it really we know has to come to the forefront, and I think we've brought it there pretty aggressively over the past few years as a collective team, not just Manchester, not just Nashua, but really trying to bring it to a statewide message with real action behind it, and that really takes a team. It's not one individual or one organization. It really is a team, and making sure everyone comes to the table, everyone works collaboratively, puts all those ideas on the table, and then you start knocking them down. And we've gotten over some of the I don't want to say the bigger challenges of resources, right? We're in a fortunate position that we do have a lot of resources today compared to where we were 4 or 5 years ago when we were like, okay, we got a couple $1 million across the state. What are we going to do? A combination of what has happened with the SOR grant that came in a couple years ago, the Governor's Commission money being up to about $10 million a year, and now even some CARES Act money that we're putting forward that is going to just be used in the short term, but can be used to create opportunities, because what we're seeing with the CARES Act money, it is COVID related, but there's one thing that I want to focus on is the gaps, right? We talk about gaps in the system for kids, gaps in the system with education, gaps in the system with mental health, and now the gap in the system with the issue of SUD, and making sure that we're getting those services to folks or families that might not be coming in for services and that aren't really in a mode the last few months of being willing to reach out or walk into the door. So we got to go find them, and we got to make sure that we're really being aggressive about the programming, the messaging, and the opportunities that are out there. It's so important, and you guys are really on the front lines at Amoskeag. You get it. I think you have a lot of interaction with folks. It's a little easier, frankly, to get out the word. Where we're also having trouble across the state is in the rural areas, right? Out in Cheshire or Monadnock or Coas or Carroll County. This is where you see some of the higher rates of addiction, where it is just a little more rural. There's a little more separation. I mean, you kind of see it in the COVID data, right? Because there's not as much COVID up there. That's actually a good thing, but it's also it's defined by the fact that folks are so separated. Sometimes they're at home for days on end, especially, their unemployment is out there. There's a lot of unemployment money. That's an awesome opportunity, but it means people are a little more home and a little more isolated, which is a safe and healthy thing for COVID, but creates all these other issues, right? Social isolation, the mental health issue, the SUD issues that can come with it, the anxieties that come with it. And then you add, if there's moms that are pregnant or going through prenatal or even postpartum issues, whatever it might be. So we got to really make sure those resources are out there. And there's a variety of ways to do it, obviously, and there's no silver bullet. There's no absolute answer. Obviously, we created the doorway system. What was it? Maybe 2 years ago now. Not even that we started that system. It seems like I'm on COVID time. So it seems like I've been here for 20 years at this point. But yeah, I guess it's almost 2 years now that we came up with the idea of the doorway system, not even. And that was all designed to have these hubs set around the state. And it's worked very, very well. We had a little challenge in Manchester and Nashua, but now that Catholic Medical and Southern have really stepped up to take over those systems, I think we're, be a little more integrated, community integrated with the concepts and kind of drive off some of the successes we've had in other states. I think it's already going very, very, much, much better. Let's just say that. But you don't rest on those laurels, right? You don't just kind of put something in place, put some money behind it and say, okay, we're good. We've checked the box. We're going to move on. You got to stay right with this stuff and stay right on top of it and make sure that not just the governor, but we're there to provide the opportunity and maybe some of the innovation to get it started, but those frontline resources and the management, right? You got to stay on top of it and then be open to getting that feedback because the doorway is an example of a brand new idea, a brand new system. It's not going to work perfect right off the bat. It's just not. And so we're trying to be very open to what's working, what isn't, where do we need to add more hours. The other big issue, not just around the doorway, but it extends in all aspects of what you guys are dealing with is workforce, right? How do we drive workforce? We were having trouble driving workforce into this field prior to COVID. Now with COVID, it's actually even harder. Hopefully that's a temporary problem. It's just harder to get folks to say, yeah, I'm going to, get back to work. I'm going to try a new field. I'm going to open myself up to another opportunity, try to help my community, engage in an organization like yours, and really get out there. But that's really where we need to drive, I think, a lot of our messaging right now. You can have the best idea in the world and all the money in the world, but if you don't have folks on the front line like Chris and her team and all of you guys, if you're not there, it doesn't matter. It all falls apart. Right? It's all about those individuals because in New Hampshire, it's about that one-to-one connection. And I think that's where we found a lot of success. Maybe that I don't want to criticize other states, but other states, especially the larger ones, have a harder time with that, managing at the top level because it's just too big. They get too disconnected. We have an opportunity here where the head of our local organizations know their clients. They know their leadership, they know their teams, and they know the individuals on a first name basis sometimes walking through that door. And that provides a lot of confidence with the public that when things aren't going right, it's okay to ask a question or it's okay to go in to ask for help because it's not just someone sitting behind a desk or behind a window. It's someone that they know and they've built relationships with. And if you can establish those personal connections and personal relationships, a whole variety of good things happen. First, the system becomes much more efficient. Folks are more proactive to ask for the help. We're, I think, a lot better at getting the feedback from the community about what's working and not working. The dollars the dollars are flowing not just to administrative programming, but really getting out the door to the folks that need the help. And again, hopefully that feedback response system is really working all the way back up the chain so we can constantly adjust the system. One of the things I found out early on in being in governor is that government is not traditionally very good at being flexible. We tend to create a system and here are the rules and the guidelines and I hope you fit in the box. You know, that doesn't work, especially in the world of SUD, right? Which is why we try to say, okay, maybe this treatment program or that treatment program or this recovery program or that mental health program might work. And if it doesn't, we'll try something else and we'll try something new. So designing flexibility in the system is one of the things that we've really tried to bring to the table. And again, that's all because of the feedback we get from folks like yourself that are on the ground. So I don't mean to go on. I could go on all day, as you can tell. I get very excited about this, these types of topics, because I just always think, we know there's more to do. There's always more to do. And there's always more ways to challenge ourselves. So whatever we can do, whatever we're missing, and I know we're not getting it all right all the time. I think we're much better off today than we were a few years ago in these areas of SUD and mental health and some of our community programs. We're going to have some tough decisions ahead in terms of budgeting, to be sure. We're probably going to have to cut or move or find $350 to $400 million in the budget. I mean, this is coming from a place last year when I had an extra $100 million and we sent all that money out to cities and towns and education. And now all of a sudden we're in a very, very different position. There are certain, what I call sacred cows, if you will, that we will not touch with funding. Things like mental health and SUD and children's programs, programs that revolve around domestic and sexual violence, things like that. If anything, we're pumping more of those dollars in, especially with some of the funding that we're getting out of the CARES Act. We just put another 11 or 12 million in this week just into those programs. And because the CARES Act is working a little differently, we can do it really, really fast. We just go. We cut the check and we go. And so when we find a need, we can address it very, very quickly right now and hopefully create some infrastructure that we can use not just today, but for the long term. I think that's some of the value of this CARES Act money coming in for some of these programs. I can't spend the money in 2021, but I can spend and use the money today. And so what we want is kind of a 3X investment there where we're putting their dollars down and it's something that can grow on itself. Maybe we're building better infrastructure, something that the state doesn't traditionally do very well, because we can spend those dollars today and that can last. We're building additional capacity today that we can use down the road as well. So it doesn't help us with the long-term operational side, but it definitely helps with a lot of the capacity issues that traditionally the state doesn't touch in. So there's an opportunity there to be sure. But even on the budget side, like I said, certain things we just won't mess with. It means we're gonna have to make some tougher cuts in some other areas to be sure. But you know, we'll make them. And but this is an area where I think when in tough economic times, and we're going to face some tough economic times for some time, these areas of SUD and mental health and abuse, these are the areas where when those that are exacerbated, right? So it makes no sense to start cutting that kind of stuff. If anything, that's where you got to put in even some more money to really make sure that those programs are working on the front lines. And like I said earlier, just being innovative and trying to be open to the idea that maybe the first couple of times we didn't get it right. It's okay to change the system. It's okay to try something new, as long as you have the flexibility to hopefully get that information and data back, and the flexibility to change when you need to change and pivot when you need to pivot, not because the governor says so, but because the stakeholders are really part of that process. I think that's what gives us a lot of hope that even through some tough economic times that might be ahead, and a higher demand on the system and a higher demand on ourselves to get our programs out there, we can be successful. There's no doubt about it that we can be successful. But look, I'm going on too long, but I just can't thank you guys all enough. Frontline workers, whatever we can do to help encourage people to get into this world, to get into this field, and say, yeah, we want to help. We want to be part of these localized organizations, and we want to be helpful about being preventative about what we're doing, not just reactive to the crisis, but really be preventative about a lot of these programs. I think that's where the opportunity really lies. And you make sure that small problems don't bubble into a crisis. That's the most important thing we can do. And so, Chris, like I said, you and your team keep doing a great job out there. Keep letting us know what we can do better on our end. And even in these kind of weird, tough, and anxiety-filled times, this is one area where I just know some good things can really come. So thank you guys very much. You've really helped us all set the gold standard for the rest of the country. I have governors calling me all the time, no joke, calling me all the time, asking, what are we doing with this program? How are you doing that? How are you doing that? We've really become a gold standard in doing it a little bit differently and a little bit better than everybody else. And so, you just keep making me look good, and we'll kind of keep shining bright for the rest of the country. But let us know what else we can do. We're going to be there for you. Thank you guys very much.
Thank you so much. All right, I'm going to give a virtual round of applause and thank you, Governor, for your participation today and your advocacy and your leadership. This has been a tough time, and we've seen you out there. You've stayed in touch, and we're all really grateful. So thank you, and my best to you and your family during these tough times. So here we have our panelists today. As a nonprofit in Manchester, we all know that we can't do this work alone. Our elected representatives in Washington, D.C., to our local representatives at the New Hampshire Department of Public Health, to the City Council, the Mayor's Office, we're amazingly grateful for the work that they do every day to raise resources for us, to raise awareness, to help create these dynamic programs, to facilitate that access in New Hampshire. And they were all so kind to provide us some information and to speak to you today about what they're feeling in the world of prenatal SUD, substance use disorder. We're going to say SUD a lot, so let me just say substance use disorder as a disclaimer for all of us who will use that term. So I'd like to turn your attention now to some videos from our elected representatives. Senator Maggie Hassan, Senator Jean Shaheen, Congressman Chris Pappas, and of course, Mayor Joyce Craig. And then you'll have some words from Kathleen Davidson, our chair of our board of directors. Thank you.
Hi, this is United States Senator Maggie Hassan. I'm sorry that we could not be together in person for this year's 13th annual Morning Matters breakfast, but I'm excited to welcome you to this virtual gathering. Throughout the COVID-19 pandemic, Amoskeag Health has been a vital healthcare resource. While navigating unprecedented circumstances, you've continued your mission of strengthening the health and well-being of New Hampshire's children, families, and communities. In the midst of this pandemic, we're all painfully aware that our state continues to feel the devastating impacts of the fentanyl, heroin, and opioid crisis. And this pandemic has presented new challenges in ensuring that those with substance use disorder can access life-saving recovery services. I am grateful to Amoskeag Health for your focus on connecting moms who are struggling with substance misuse to the resources they need to keep themselves and their children healthy. Through the Perinatal Substance Use Disorder Program, you're providing vital support for moms and children, and you are helping them improve their lives. Thank you for all that you are doing. By working together, we can continue to address the challenges presented by COVID-19, tackle substance misuse, and strengthen our communities. Stay safe and stay healthy.
Hi, I'm Jean Shaheen. Thank you for inviting me to join you virtually today and for all of your great work in keeping Granite Staters healthy during this difficult time. While we're in the middle of a global pandemic, we must not forget that New Hampshire also continues to combat a substance use disorder epidemic, especially for women who struggle with substance misuse during and after childbirth. Amoskeag Health's Perinatal Substance Use Disorder Program has stepped up to help confront this challenge by providing substance use disorder treatment to pregnant women and new moms. I will continue to fight for more federal funding to support medication-assisted treatment for pregnant women and parents so that Granite Staters can get the support they need. Thank you again for your efforts to help prevent and treat substance use disorders. Have a wonderful day and keep up the great work.
Hi everyone, I'm Congressman Chris Pappas. Thanks for inviting me here to join you all today. I'm honored to speak alongside the panel of substance use disorder experts. I want to start by sharing my gratitude for the devoted doctors, nurses, and staff at Amoskeag Health. They are meeting this public health crisis head on and are continuing to provide comprehensive services and a family-focused model of care that empowers patients and strengthens our community. They are community heroes, and we are so thankful for their work. I want to also thank the hundreds of Granite State business and civic leaders joining us virtually as we celebrate the vital work Amoskeag Health provides and discuss the challenges that lie ahead. Unfortunately, New Hampshire knows all too well the severity of this opioid and addiction epidemic. There is a uniquely tragic and often underemphasized face of the crisis, its effects on pregnant women, new mothers, and babies. Women struggling with substance use disorder are also more likely to face malnourishment and domestic violence. And babies born to mothers battling addiction are also at higher risk for neonatal abstinence syndrome. In fact, every 15 minutes in this country, a baby is born into opioid withdrawal. That is why we must make maternal care and mental health treatment more accessible and affordable. Fortunately, Amoskeag Health and other New Hampshire care and treatment centers are doing just that. Their innovative model, maternal opioid misuse, also known as MOM, integrates physical health and behavioral care services in a cost-effective way for patients by working with Medicaid. The work that they are doing is without a doubt improving the lives of so many of our community members, and I'm so thankful for that. And if you know anyone struggling with addiction, please call 1-844-711-HELP or visit newhampshiretreatment.org to learn more about the resources that are available. Thank you, everyone, and stay safe.
Good morning, it's Mayor Joyce Craig, and welcome to the 13th Annual Morning Matters Breakfast. As Mayor of the city, I just wanted to mention how grateful I am for all that Amoskeag Health does for children and families throughout our community. We really couldn't support all of the needs without you, and I just want to thank everyone for being here and supporting their efforts further. Have a great day.
Thank you very much. And I believe that we have an introduction from Kathleen Davidson, our board chair, that will be coming up. So I'm gonna keep moving until I see that video arrive. Hopefully you can bear with me while we get that queued up. We've become a Zoom webinar specialist in a matter of 2 short weeks. And I think, like most of you who have been trying to do your business in new and creative ways, it's a fun and interesting challenge to figure out how to do this. Oh, here we go. There's Kathleen.
Good morning. I am honored to serve along with 15 other volunteers on the board of directors of Amoskeag Health. Together, we oversee the financial sustainability of Manchester's Community Health Center. Amoskeag Health delivers over 55 different programs to nearly 15,000 people annually in 61 different languages. People of all ages, genders, ethnicities, and social economic backgrounds call Amoskeag Health their primary care provider. Services are provided without discrimination in a caring, compassionate, and culturally sensitive environment. Today's topic of substance use by women before, during, and after childbirth is critical to the well-being of our children and their families. Amoskeag Health is not in this battle alone. Partners make it possible. They include the Mental Health Center in Manchester, Waypoint, Hope for New Hampshire Recovery, Catholic Medical Center, and Families in Transition. And a heartfelt thank you to the foundations who fund the staff and resources: New Hampshire Charitable Foundation, One-to-One Foundation, Elliott Health Systems, and Bi-State Association. Thank you for tuning in this morning.
Thank you. And you can see why I decided not to do this from home, because I would have had 2 dogs doing exactly that during this presentation. Thank you, Kathleen, and to all of our elected representatives who work so hard on our behalf. We're so grateful for the time, and we have to take a moment and acknowledge the volunteer committee that works every year to help us put together this Morning Matters event. First and foremost, our chair of our committee, we have to thank Judith Jolton, who has served in that capacity for 13 years. If you know her, her unwavering energy, and her organizational skills and her drive to perfection, you will understand why she's such a wonderful chair. And I have to thank our committee members who've been doing this for many years: Elizabeth Ashew, Helen Cormier, Laura Gilman, Joan Gustafson, and Tom Lavoie, who also sits on our board of directors, along with David Crespo, who is also on our marketing and development committee and serves on our board. So my thanks to all of our board members and volunteers and staff that work every year to make this possible. Now it is my honor to present our keynote speaker, sponsored by People's United Bank. Daisy Goodman is a practicing nurse midwife with many years of frontline engagement in caring for women whose pregnancies are complicated by drug and alcohol use. In her current role at Dartmouth Hitchcock, she directs women's health services in their multidisciplinary perinatal addiction treatment program, an innovative integrated care model launched in 2013 that so many of us have looked to for guidance. Daisy's areas of research and clinical interest are in the areas of complex factors that impact women with opioid use disorders and the development of optimal treatment approaches. Her work, therefore, is focused on understanding women's experience of prenatal care and opioid use treatment and barriers and facilitators to implementation of evidence-based care models in this vulnerable population of women and infants. And I'm going to now yield the screen to Daisy Goodman, Director of Integrated Women's Health Services at Dartmouth Hitchcock Moms in Recovery Program. Thank you, Daisy, and welcome.
Thank you so much. It's certainly a privilege to be able to speak with you and also to moderate this panel of experts. So I wanted to take a minute just to get the sense of the audience first. Because we're having to meet by Zoom and we can't participate in person, we thought we would ask you a poll question. So if you will grab your mice, please. We are going to ask a question here. Are you close to someone who suffers with a substance use disorder? And please give us your answer. These are anonymous. So I'm not actually able to see the results. So if somebody who can, oh, here we go. There you go. So we're a split 50-50. So clearly a very serious problem in our communities that affects at least half of us on a very, very personal level. Next slide, please. So I wanted to take a slight digression to look at impacts on women sort of more broadly. We have over the past months been more and more aware of the importance of public health in every aspect of our lives. But while we've been focused initially on the opioid use epidemic and now on the coronavirus pandemic, there's been a slow burning, smoldering epidemic that has been affecting women in this country for decades, and that is maternal mortality, defined by the CDC as death of a woman during pregnancy or in the first postpartum year. And this maternal mortality has worsened over the years and is becoming, it is, I would say, putting our nation to shame because we're doing much worse than other countries. It's important also to acknowledge that, like the other epidemics that we're seeing, there is a totally unacceptable racial disparity in terms of maternal mortality. Next slide, please. And the contribution of opioid associated death to maternal mortality has increased in the past decade, from 4% in 2007 to now fully 10% of that curve of ever increasing maternal mortality that we see in this country being due to opioid overdose. And if we look at national data, 70% of these deaths occurred during the 6 weeks postpartum. So really critically important to think about how we support postpartum care for women. And interestingly, and the racial disparity has actually been recently reversed for opioid-related death, with white women dying more than Black women, although that is unfortunately also changing now, and now everybody is being equally affected. So in the state of New Hampshire, we had 12 maternal deaths occurring between 2016 and 2017, 9 of which were directly attributable to substance use and 6 of which were caused by overdose. The vast majority, again, of these occurred postpartum, and we know that both substance use and mental health conditions were risk factors actually in all of the deaths that occurred. And for this reason, we are very privileged to have received a CDC grant to enhance the work of our Maternal Mortality Committee. I just wanted to highlight this concept here, that we really have to think about all of the factors that impact women, and particularly the factors that provide barriers to participating in effective treatment. Next slide, please. So the promise of integrated care really is that we can address those barriers. We can address them through immediate access to treatment by providing substance use treatment at the point of location of our perinatal care. We can address co-occurring mental health conditions, and we can provide the psychosocial supports, care coordination, and care management that is desperately needed. And I am happy to say that that is what Amoskeag is most is excelling at right now, right here in Manchester. So it is a privilege to be able to introduce our panelists now, starting with Dr. Gary Kaufman, who is a diplomate of the American Board of Obstetrics and Gynecology with certification in maternal fetal medicine. He is a fellow of the American College of Obstetricians and Gynecologists and a diplomate of the National Board of Medical Examiners. Dr. Kaufman is an assistant professor of obstetrics and gynecology at BU School of Medicine and currently works at the Elliott Health System as a medical director for labor and delivery. Dr. Kaufman.
Hi there, good morning. I actually haven't been a professor at BU in a couple of years. That goes back about 20 years. But interestingly, that's where I got my first introduction to the world of substance abuse back in the days of Boston City Hospital. And Daisy, I'm embarrassed to admit that when I looked at your slide going back to 1987, I've been doing this for that long. I thought I'd give a brief overview of just opioids in general, because I think especially the public doesn't always have a good understanding of what's going on with them and what they are. And I think it's just a good backdrop for everything that goes on. I will try to race through this really quickly. It's probably a 45-minute lecture that I'm going to do in about 4.5 minutes. And Chris, your job is when I get to about a half minute left to tap me on the shoulder and tell me to curtail it quickly. So opiates go back almost 6,000 years. There's evidence of opiate use in Egyptians and Mesopotamians. And natural opiates are all derived from the opium poppy, which is interestingly a very beautiful plant. One of my old mentors made the comment that while animals developed speed, teeth, quills, shells as ways to protect themselves, plants had to become synthetic chemists. And so plants managed to make all sorts of good things. Whoops, you cut ahead on me. Go back once, thanks. Plants managed to do all sorts of nice synthetic things. As everyone's holding their cup of coffee, they synthesized everything from quinine to opiates to caffeine to tobacco and nicotine. So natural opiates are derived from the opium poppy. Next slide, please. And so opium contains a mixture of chemical that are opiates. The most well-known is morphine, which was isolated in 1803. And for those of you who are fans of the Matrix, Morpheus, the Greek god of dreams, is the origin of the name morphine. It was commercially sold as far back as 1827. Next slide, please. The other natural opiate that is included in the extract of the opium poppy is codeine. And codeine is actually metabolized by the body to produce morphine. Next slide. So natural opiates can then be chemically altered, and they are then chemically altered to make them typically stronger, more absorbable, longer lasting, and we're familiar with a lot of these. So these semi-synthetic opiates, where you start with the natural opium poppy extracts and you chemically alter them, include adding things, I'm an old chemist, so bear with me, but adding things like OH and double bond O's to things, so you can take codeine and make hydrocodone, you can make oxycodone, and these are all things that we know on the street as Vicodin or Oxys or Dilaudid, Percocet. Next slide, please. And so for those of you who like pretty molecules, there's morphine up at the top, and then going around from the right, there's Opana, there's your Oxys, your hydromorphone is your Dilaudid, hydrocodone is Vicodin, and then way around the left is the one we're going to talk about more in a second. Next slide. So those of you may remember the story of aspirin. A synthetic chemist working for a company whose name is pretty well known in the aspirin business, Bayer, had a father who had arthritis, treated him with salicylic acid, and it was tough to keep down. It's a drug that's very irritating to the stomach. It's not well absorbed. So being a good chemist, he said, how can I change this? And he added acetyl groups to it. And he came up with acetyl salicylic acid, which is aspirin. Interestingly, Bayer doesn't like to talk about this much anymore, I suspect, but the same chemical process was then used for morphine. And so the two little chemical groups sticking off to the left side of that molecule are acetyl groups. And this is now a semi-synthetic opiate. So you take morphine and you add two acetyl groups to it. Next. And so in 1898, Bayer Corporation actually began marketing a new drug, which they thought was heroic. And so using the word, my German is terrible, but heroisch, however you pronounce that, they coined the phrase heroin and started marketing it. And if you look in the middle left of that slide, you'll see it was marketed as a sedative for coughs. Next slide. And heroin is a uniquely good drug in terms of doing all the things you want to do if you want to be addicted. And so in the same way that nicotine crosses very quickly from a cigarette across the brain, so does heroin. If it's given IV, it gets to the brain very, very quickly, produces a huge rush. It's very quickly metabolized to morphine. And so it has all the properties that make a drug very attractive to the brain. And addiction to heroin goes back over 110 years in this country. The first admitted case of heroin dependence in New York City was in 1910. And heroin has been illegal in this country since 1924. Next. So one distinction is that opiates are natural plant products. So they're essentially, for most of us, they're morphine and codeine. Opioids are drugs that attach to the same receptors, and they can be semi-synthetic, so the ones we've been talking about, your oxys, your dilaudid, your heroin, or they can be completely synthetic, drugs like fentanyl and methadone. Next slide. And so methadone was synthesized by the Germans in the late 1930s. Because of the war, they were unable to get to the opium poppy fields. Being very good synthetic chemists, they came up with a drug that attaches to the same receptor. And in fact, methadone has long been used in the cancer world for pain control because it's very long acting. That's the same reason it's generally chosen. For many years, it was the mainstay of therapy for opiate addiction because you can dose it daily because it's so long acting. Next slide. Interestingly, another drug that is also an opiate is Narcan. Now, you're probably saying to yourself, wait, that's the thing we give to people who have overdosed. Well, it is because it attaches to the same receptor, but it doesn't turn the receptor on. So it kicks off other drugs that are there. So if you've got lots of heroin stuck to your opiate receptors and you give Narcan, Narcan will bump a bunch of it off and let the receptor turn off because it doesn't actually act at the receptor. Next slide. There's also a bunch of drugs that are sort of halfway between Narcan and the pure opioids. And these are drugs that stick to the receptor, partially turn it on, but they have the advantage of, because they don't completely turn it on, you can give more and more of it without precipitating the sort of lethal overdose. And this is the reason that drugs like Subutex or Suboxone are widely used in treatment, because they're safer to hand out to the public because it's much more difficult to overdose with them. Next slide. And so if you think of it as sort of the three categories, you have Naloxone or Narcan at the bottom, which sticks to the receptor but doesn't turn it on. So it's got no opioid effect. You've got your partial drugs like buprenorphine, which turn on the receptor somewhat, but at some point don't turn it on anymore. So again, harder to get the respiratory depression or kill people with. And then you have your full agonist drugs, which the more you give, the more you turn it on. So methadone, heroin, morphine. Next slide. And again, buprenorphine has a long duration of action, so it's a good drug in terms of treating opioid dependency. It's got a good safety profile because it's harder to kill yourself with because of this ceiling effect. Next slide. You'll hear people talk about Subutex versus Suboxone. Suboxone is a very interesting concept. It's actually buprenorphine plus Narcan. So again, you're probably thinking to yourself, wait, why are we treating somebody with a drug that's the antidote? Well, it turns out that Narcan is very poorly absorbed orally. So if you take it like you're supposed to, the Narcan basically doesn't get into your system. But if you try to be a wise guy and snort it or abuse it in some way, the Narcan kicks in and you basically treat yourself for opiate addiction by throwing yourself in withdrawal. So it's a safer drug to have on the street. Next slide. Fentanyl came around in 1959 as Sublimase. It was used originally as an IV anesthetic, and nowadays it's almost completely displaced heroin on the street. And the reason for that is because it's synthetic. You don't have to grow you don't have to grow poppies to get the substance. It's also much more potent. It's 80 to 100 times stronger than morphine. So if you're trying to smuggle something, you don't need to smuggle nearly as much. Next. And there are literally dozens of fentanyl-like drugs. And if you have really good vision and can see the middle of that slide, carfentanyl's in there, which has gotten some press. Carfentanil started out as a large animal tranquilizer, and it's a tremendously potent drug. The other drug that's gotten a little press is way toward the bottom of the slide, U47700 or U4 Pink, because that one's definitely hit the streets. Next slide. And so in terms of relative potency, codeine is about 1/10 as potent as morphine, heroin 2 to 3 times as potent. Then you get down to fentanyl, which is 100 times as potent as morphine. And so you can see why we're seeing many more overdoses than we did even in the past. And carfentanil is 10,000 times as potent. So if you're an elephant, it may be the right drug for you. But for the rest of us, it's really dangerous drug to see on the street. How did I do for my 5 minutes? Did I talk fast enough?
Thank you, Gary. That was great. That was the best, shortest history we've ever seen.
That's right.
Thanks.
It's my pleasure now to introduce Dr. Mary Cullen. She is a family medicine doctor in Manchester and affiliated with Elliott Hospital. She has practiced at Amoskeag Health for 10 years, where she specializes in family practice and obstetrical medicine. Dr. Cullen, thank you.
There we are. Hi, everyone. So I wanted to take a little time to tell you about how I came to be doing what I do. My passion for treating patients with substance use disorder started in 2005. It was my 3rd year of med school in Lancaster County, Pennsylvania, when I heard a morning report about this new medicine that had come out recently called Suboxone. It was a time in our training that most med students were trying to figure out what we wanted to do when we grew up. Every rotation we did, we learned about something new, and I wanted to be a pediatrician. I wanted to be I never wanted to be a surgeon, but you always looked at what you wanted to, changing the way that you were thinking about things as we learned about things. So when I heard this morning report, I was like, wow, that's really cool. I want to do this. I told my roommates at the time I wanted to treat patients with it in the future. Then I moved on to something else in my next rotation, and I thought that was really cool. And the buprenorphine, when I had learned about it, we had never really talked about addiction in medical school. It was my first look really into addiction and medical treatment. So if we fast forward to residency, I had many patients on methadone, but I wasn't really involved in their care for substance use disorder because the care had to be provided in a separate certified opioid treatment program. I've been hearing about buprenorphine use, but there really weren't any providers prescribing in Concord at the time. We did have a few patients who came through a residency program who were pregnant and prescribed buprenorphine, and I saw the differences in the care of the newborn of moms on street drugs versus buprenorphine versus methadone, and just how much better babies did when their mom was on the buprenorphine. It still really wasn't a thing in our area, so I didn't really think about it all that much because I was in a busy residency program and I didn't have as much time to think about that stuff. After moving to Manchester and starting at Amoskeag Health, I noticed how many more pregnant women we had with SUD. Of those in treatment, most were still on methadone because buprenorphine, you still weren't able to find it as widely prescribed, but I was seeing it used, and I really started seeing the difference in care that we were giving in the hospital. Because after delivering the babies as family practice docs, I then follow the babies, admit them to the hospital, and treat them while they're in the hospital, which is why I love being a family doc. But I just saw so much difference in the length of the stay of the baby. All of a sudden, babies, not every baby, but going home in 5 days versus in 2 months. But at that time, there still weren't really many options to access care with a provider who prescribes buprenorphine, publicly at least. I knew of a few primary care providers prescribing it to their patients, but there were limited opportunities to get it outside of those offices. To prescribe buprenorphine, a provider needs to do extra training and complete an application process to get an X waiver from the DEA. After hearing a talk at our New Hampshire Academy of Family Practice medical education meeting, I had my interest in prescribing buprenorphine for this population completely renewed. I remembered that I had heard about this medicine way back in 2005, and I still thought it was really cool. There were 2 ways to take the training back then. A block of 8 hours in person, which was actually kind of hard to find at that point, and a half and half. where we do 4 hours of live online and 4 hours of self-study. So I signed up for a half and half training over a holiday weekend at the end of 2012. It was on the West Coast time because that's the only way that I could do it. So I actually started at 11 o'clock at night and went through the early morning because that's when I had the time to do this kind of thing. And then I started working to create handouts, consents, questionnaires. I talked with Dr. Kaufman a lot about treatments, picking up a lot of good pointers, answering all my questions. He was really helpful. And I enrolled my first patient in March of 2013. A pregnant patient who, at that point, who was pregnant, who I still have as my primary care patient, which is actually, I think, is really cool. I had really looked into getting my X waiver to specifically treat our prenatal population because I saw it was such a huge need for that. But shortly after, my primary care patients started opening up about their opioid use. I'm not really even sure they knew I was prescribing buprenorphine at that time, but patients started coming in and saying, like, I really want to get some help. You know, I've sold all of the jewelry that I've gotten from my partner to use for drugs, and now I'm trying to wear something nice and I don't have anything left. Or moms that were desperately trying to get help for their child. So soon I was seeing all sorts of patients, male, female, pregnant, postmenopausal, and still seeing them as part of my primary care panel. In 2015 at Amoskeag Health, a new administrator was hired and we started creating official policies to build up our program. We had a lot more behavioral health support by that time, and we were able to reorganize the care into blocks of times, so patients would have direct access to counselors during their visits, and it made scheduling follow-up appointments easier, as we had many more patients enrolled at that time. Our MAT program has now expanded significantly, with success using an integrated care model made up of a multidisciplinary team consisting of now 4 waivered providers, a master's level alcohol and drug counselor who you'll meet a little bit later on this morning, certified recovery support workers, a nurse dedicated just for our patients, our medical assistants, and a urinalysis technician that comes in for every office block that we have seeing patients. We prescribe 2 different medications. One is that buprenorphine, better known as Suboxone, and then the other is the Naloxone or Vivitrol. Vivitrol is a long-acting injectable. This is basically long-acting Narcan, a sibling, I guess, to Narcan or cousin. Our program right now sees 98 active patients receiving medication, 92 on Suboxone, 5 on Vivitrol, and 1 on the Naloxone tablets. We have 3 phases to our programs. Our first phase is the induction phase and getting stable, and that's phase 1, where you're seen weekly by the prescriber and by your individual counselor. As you get stabilized, you can go to bi-weekly and then monthly visits. And some people are on weekly for a really long time, and I've had patients on monthly for a really long time. And really, a lot of a program like this is about meeting patients where they're at and trying to come up with a really good way to support them through their recovery. We require recovery activities, which could vary in doing counseling, online meetings. Right now, the COVID era kind of recovery activities are either meeting in a park, standing really far apart from each other, wearing a mask, trying to do something in person to get that support, or there's tons of Zoom meetings now. There's been a lot of, just like everyone else, we're all doing this virtual programming. So all of the recovery activities, AA meetings, NA meetings, there's a lot more offered at this point. But some patients, some people want that in-person kind of treatment, and that is, and meetings and stuff, and that support, and that's what's making it really hard for some people. Even though there are all of these things out, and so maybe those of us that are on here that know how to get on a computer and get on a Zoom call, have the access to a computer, that might not be for all of our patients. So hopefully we're gonna, at some point, get patients back into where they would be better treated, if that's a live meeting or whichever. And then we do have every appointment, you would get a urinalysis done that we send to an outside company that looks at all sorts of different illicit substances, also can tell us if they're taking the correct amount of drug, or what's even cooler is we can tell them whether or not they're doing a good job quitting smoking, because we test for nicotine levels, and you can see those go down, and it's a really exciting thing to say, like, look at that, you're doing such a great job, your nicotine level has gone down this much, so keep working on it. So I feel really lucky to be part of this team providing great care to this difficult population of patients. My hope in the future is that treatment will be accessible to anyone who requests it without the long wait that has historically been a really big barrier to finding care. It really should be a part of every medical school and residency training. I really hope that more OB providers or family providers or ER providers, everyone, will see the benefit of prescribing buprenorphine for their pregnant patients or patients in general. Or at least know where to refer the patient seeking help, since now there are not enough supports there and places to find things, but a lot more than there were before. So I thank everyone for being here and supporting us today. And I really look forward to hearing the rest of the panel and answering any questions you might have.
Thank you so much, Dr. Cullen. I'm now very pleased to introduce Dr. Molly Rossignol. She's a graduate from the University of New England College of Osteopathic Medicine, completed a residency in family medicine, and has worked in this field for 15 years. She pursued a fellowship in addiction medicine at University of Wisconsin in Madison, and then returned to her state of New Hampshire and has been active in assisting with developing policies, practice guidelines, and training programs while pursuing best practices for patients with SUD. She participates on several state task force, hospital committees, and medical society activities, and has worked for New Hampshire Healthy Families as a medical director for substance use disorders since August of 2019. Thank you, Dr. Rossignol.
Thank you, Daisy. Can you hear me?
Perfectly.
Perfect. Alcohol and other drug use disorders are the most stigmatized illnesses in the country and in the world. Seeking treatment for many is difficult, as many don't know where to turn. People with use disorders have expectations that they will be treated as less than, or that their needs will go unmet. This is not unfounded. It's likely that they have experienced discrimination and ineffective care. Pregnancy can exacerbate the shame of seeking treatment. A woman may fear that using substances or being treated for a use disorder puts the custody of her child at risk. In some states, women face legal and punitive consequences, even being charged with child abuse while pregnant. Some women don't believe that anything will help them recover, and some are so ill, being a brain illness, and the brain being so affected, that they cannot accept treatment while continued drug seeking and compulsive behavior is present. Next slide, please. State-funded insurance programs are involved in the majority of for a woman with opioid use disorder. Likewise, their baby's care is also covered typically by state-funded insurance programs. In New Hampshire, Medicaid managed care organizations such as New Hampshire Healthy Families provide resources through care managers who can act as part of the care team for pregnant women. These nurses have experience in obstetrical, neonatal, as well as substance use nursing. Care providers should encourage their patients to contact her MCO, or care providers can also refer their patients to their MCO, to the patient's MCO, so that she can establish a prenatal care manager and learn of community resources. In a study using patient navigators, women such as a care manager, women who had these services increased treatment adherence, saw improvements in opioid abstinence and depression scores, and overall general health. I also want to inform physicians and other providers of the requirement to create a plan of supportive care with their pregnant patients who are affected by substance use. This document will be utilized to support the mom and her baby postpartum, both to navigate and help her participate more easily in her and her baby's treatment planning. Care managers can also assist in preparing mom for the development of this document. Next slide, please. It's been my goal to be a voice for patients and to find solutions to addictive disease. We talk about the problem enough. This illness affects nearly every human being. While stories of recovery, which typically follow a line of what it was like, what happened, what it is like now, can be heard, this humanizes the experience. This reduces stigma. This gives hope to people who suffer from this illness. I advocate for policies that will reduce barriers to care, that will encourage treatment that works in all settings, and offering people care that is appropriate for them and meeting them where they are. Educating providers on these concepts is something that must continue and be repeated. The effect of witnessing how well someone can get in recovery is invaluable. Thank you.
Thank you so much, Dr. Rossignol. It's now my pleasure to introduce Megan Smith, a nurse leader with 16 years of perinatal nursing experience, a member of the New Hampshire A1 coordinating team, and director of pediatrics, women's, and children's services at the Elliott Health System since 2016.
Good morning, everyone. I hope you can hear me. So I'm going to be really quick because we're running a little bit behind, but I just want to share with everyone, briefly our journey here at the Elliott in regards to what we do from an inpatient perspective. Hopefully you can you all still hear me?
Yep.
Okay. So we embarked on a journey to the Eat, Sleep, and Console model here at the Elliott about 2 years ago now. It actually, in July, will be 2 years. And I had previously been at Dartmouth-Hitchcock, worked with Daisy in regards to what we were doing up there, and really felt as if we could embark on this journey down here in Manchester. And so we introduced the model, like I said, 2 years ago. We had been seeing a length of stay for patients that was upwards of anywhere from, like Mary said, 24 to, sometimes even 40 days. And it was really about ensuring that we could continue to, model our care with family-centered, ensure that, our moms and our dads and our significant others and whatever supports the patient had could continue to participate in the care. And we felt as if at 24 and 40 days, that became harder and harder for patients and for moms and for families to do that, whether that was because there were other competing priorities at home, other children that they were caring for, continued treatment for them, which is so important for them to continue to be able to care for their babies. We really embarked on this journey. And so we've had a lot of success here at the Elliott, really reducing our length of stay down to anywhere from 5 to 7 days for the majority of our patients. And really sort of setting them up for success to get back out into their community and continue to receive care where it's really most important for them. Some of what we're embarking on now that we're 2 years into the model is really looking at our data to understand where do we go from here? How do we improve what we're currently doing? And one of my passions is really around maternal mortality, and Daisy showed some staggering statistics at the start of this. And so, part of what I'd like to do here at the Elliott is really start to understand how we can affect change from a postpartum standpoint, that even when they're not here as an inpatient, we're continuing to set them up for success when they go home. So really that's, our model. And I'm hoping that with some of the videos that you'll hear from moms who have come through the program, that family-centered approach, really involving them in their care for their baby and understanding that they are the #1 treatment, if you will, for their babies is incredibly empowering. And I think that's what it actually gives me the chills as I sit here and talk about it, because, it just gives them such a sense of purpose. And I think that's, one of the most critical things in their recovery. So I'm looking forward to the videos, and, my information is out there if anyone wants to understand a little bit more about what we do. But I appreciate everyone's time and love the partnership with Amoskeag, and I appreciate everyone's time this morning.
Thank you so much. I'm now going to introduce our last panelist, Nina DeMarco, a dually licensed clinician who received her MLADIC in 2018 and LICSW in 2019. She began at Amoskeag as a graduate intern in 2016 and today is Amoskeag's Substance Use Disorder Program Manager.
Thank you, Daisy. Thanks. Good morning, everyone. So my hope this morning is to talk to you a little bit about co-occurring disorders. And so when it comes to treating a substance use disorder, it is also extremely important to also treat any co-occurring mental health disorder. And in simple terms, co-occurring means anyone who might be struggling with a substance use disorder also has a co-occurring mental health disorder. You may have also heard of this as dual diagnosis. So looking at this figure in front of you, you can see that a person's biology and environment combine to influence the way they think, feel, and behave. This creates risk factors and protective factors that in turn impact how likely someone is to develop a substance use and/or mental health diagnosis and how severe these diagnoses may be. Next slide, please. When treating a substance use disorder and mental health disorder, is also extremely important to assess the individual's recovery environment. When clinicians and providers determine the appropriate level of care for a patient, their recovery environment is looked at very closely. So we look at who they have for their lives, for their support, family, friends, significant others. We look at any financial, vocational, educational resources or concerns. And we also look at things like housing, legal concerns, if they have transportation, and anything that might come in the way of getting childcare services. We also know, as I'm sure many of you do, that addiction impacts the family system as a whole. It can cause emotional, medical, legal, financial consequences. It can take a big toll on relationships with spouses and children. It can cause trust issues, social disconnections, and these can last short or long-term effects. And as we know, as research has shown, children are more likely to develop a substance use disorder or mental health disorder if their mother and or father struggle with addiction. Next slide, please. So I'll talk to you a little bit about prenatal substance use disorder resources here in New Hampshire. There are many of them here in New Hampshire. A lot of them were talked about already. We're lucky to have a lot of great resources here, not only for prenatal women, but also for anyone struggling with a substance use disorder here in New Hampshire. If you don't know where to start, as referenced earlier, you can go to newhampshiretreatment.org, and that's an easy way to explore what's offered here in New Hampshire. You can also go online. There's a lot of great stuff on there. And you can also simply call 211, which I don't think a lot of people know, but if you call 211, you can get connected to a live staff member who will provide you with the services here in New Hampshire. And as Governor Sununu talked about earlier, the Doorways is a program about 1.5 years, 2 years old, better known as Safe Station. But it's been a great resource here in New Hampshire. There are 9 doorways, and we're lucky to have one here right in Manchester, right on Hollis Street. You can walk in there and get connected to the services usually that day. So it's a great resource to have, and there's a lot out there. And I think I can speak on behalf of myself and the team here this morning that we're hoping you feel a little bit more confident in the knowledge about substance use and prenatal resources. And we thank you for your time today.
Thank you so much, Nina. So now please listen to some firsthand accounts from strong moms who sought help for substance use disorder and delivered healthy babies.
Hi, my name's Crystal. This is my son Jackson, and we would not be where we are today without Amoskeag's help, love, support, courage, and flexibility.
Hi, my name is Samantha, and this is Ariana. I'm a mother in recovery. I've been clean about 4 months now. She's so beautiful, isn't she?
Hi, I'm Liz, and this is my son Elijah. Throughout my journey, pre and post pregnancy, the most important things for myself and Elijah were my Roots for Recovery program and the Thrive program, which are based out of the Pregnancy Care Center at CMC. They did educational courses to help mothers know what to expect when their babies were going to be born and what to expect while you're pregnant. They also offer incentives, which is super helpful for a lot of moms that don't have anything to get started with. So it's been a huge help for both myself and this little guy who was born at 3.5 pounds, and now he's super healthy and happy, and it's all due to the support that I got from the Pregnancy Care Center's Roots for Recovery program and the Thrive program.
Hi, I'm Bristol. I'm a mother of 3, and my journey begins 5 years ago. I was a substance user. I was addicted to heroin. and pregnant with my first child. I found resources and I was led to the Nashua Cynthia Day program. It's for women and children, and my life completely changed for the better. I was able to have my child and stay there with my child after he was born. I grew up in a good home, you know. I had a nice house, a beautiful neighborhood, good school, and it was like dangerous. You know, I was curious. First it started with just smoking weed, and then it got into the heavier things. I also was put on the Methadone clinic, so that was a huge help as well. I'm still currently on the Methadone clinic. I've been working my way down, you know, trying to get off of it because I think that I have all the tools and I'm at a point in my life where I'm ready to do it on my own. I'm always going to have that addict, you know, behavior in me, but it's how I use it, how the tools that I've learned along the way is what's going to make or break me. You know, I'm either going to mess up my day or make it a good day. You know, just because I wake up on the wrong side of the bed doesn't mean my whole day has to be ruined and I have to go get high over it or something. When I was pregnant with my son, I finally was able to have a purpose, and it gave me a reason to want to do the right thing. I was going to my meetings, going to counseling, and doing all my steps and doing what I'm supposed to be doing to be a better mother, to be a better person, a daughter, be a better friend, trustworthy. You know, I was never, nobody could trust me, nobody, you know, my mom wouldn't even want me over her house, and now she gives me the key to her house. He was only in for 5 days. He got to go home 5 days later. Both my son and my daughter were in the hospital in the NICU unit for 35 days. It was hard. It was very hard, especially being a new mom. I broke down like 3 or 4 times a day. I changed my whole lifestyle, my whole life around because I didn't want to subject my children to that.
Hello, everybody. My name is Lisa DeBricta, and I am the Associate Medical Director of Pediatrics here at Amoskeag Health. This is a very unusual way for me to deliver my yearly message, but I want to let you know that we are doing very well, that we have really worked hard during this pandemic time to provide excellent care for our families and children. Thank you for listening to all of these wonderful stories, and we continue to provide a non-judgmental approach to care for mothers and families who are dealing with addiction, who are in recovery, and have enjoyed respect from our providers, from our team, and that will continue to happen. We also have done a great job of providing that safe care at the Dr. Selma Deitch Center for Children and Teens for all of our prenatal visits, for our medically assisted treatment program, and for the children who have come in to be able to keep up on their immunizations, which has been a challenge nationwide as people have been nervous about coming into for medical care during this pandemic. We have been able to keep our patients separate so that our patients who have been sick have gone to the Hollis site, and the Elm Street site has been able to provide care for families who needed it on a continuing basis. We very much appreciate your support in the past, and we know that you will continue to support us in the future. We hope that now more than ever, your donation will be available to strengthen this ability for Amoskeag Health to provide and support healthy outcomes for families like Bristol's. It has been nearly 40 years that the Dr. Silmadich Center for Children and Teens has provided this kind of service for our Manchester community. And we thank you as we continue to change lives in New Hampshire and in Manchester in particular, for people like all of us, like Crystal, Liz, Samantha, and Bristol and their wonderful families. Thank you.
I want to take a moment now to thank all of you for the wonderful care and the wonderful time that you've given us, to our speakers today who just did a fantastic job of trying to give you some information to familiarize you with the programs and the services that are being offered in our state, in our community, and here at Amoskeag Health, to our sponsors for the wonderful work that they've done in giving us this opportunity to continue this time-honored tradition of Morning Matters, and to all of you during this very unusual and crazy time. We miss you. We look forward to seeing you all again in person next year, where we can enjoy a handshake or a hug and the ability to see your smiling faces. But for now, my gratitude to everybody who's participated today, and thank you for your support. The information is available on the screen that gives you the ability to donate, and there are multiple ways to do so. You can pledge a text, you can donate online, or of course you can mail checks, although we wouldn't want any of you stopping by because we want you to protect your health and well-being. So please take advantage of one of those opportunities. And again, my thanks to all of you. Take care.